Good afternoon, everybody. Short of time, I've got onto the stage without being invited.
We invite Dr. Thomas sir to guide us through understanding ACYANOTIC heart disease.
So I think after a lot of legal talk, it's time to get back to some clinical work. And it's truly a great initiative that Dr. Amresh and his team is doing with a specific aim of reigniting interest in cardiac surgery. So I always, during my MBBS also I had this, somewhere along it came along, and during my third year I had this curiosity to go into the cardiac surgery theater. So I still remember the main surgeon was taking down the lima. He was taking down, and then I quietly opened the door and entered. He looked up and he asked, "Who are you?" I said, "I'm a third year student." Nothing else. He said, "Get out." That was the way we were embarked onto cardiac surgery. And now you see the time has reversed and have changed, and we are now the seniors like Dr. Amresh are, they're hunting to get people back into cardiac surgery. And it's truly not a and all along the way we've been told, don't come into this field, don't come into this field. But, who's that? Steve Jobs said, stay hungry, stay foolish. So there'll always be fools, there'll always be hungry people. And I'm glad to see this hall is still full of foolish and hungry people. So I'll just start off with the basic aspect of ACYANOTIC heart disease. So how many of you are MBBS students? Okay, most of them are MCH. Okay, then good. So we broadly classify them. Traditionally, they're classified into left-right shunts and obstructive lesions. But in fact, ACYANOTIC heart diseases are a much bigger group of lesions. They include Al-Kappa, the valvular lesions, and all those lesions. But traditionally, it's left-to-right shunts and obstructive lesions. So during this talk, I'll just stick to left-to-right shunts. So if you take the whole spectrum of ACYANOTIC heart diseases, you'll see that if you look at the survival curves of heart diseases in general, the green one shows the survival curve of a normal population. The red one is actually the survival curve of ACYANOTIC heart diseases, and the blue one is the survival curve of the total cohort born with cyanotic heart diseases. You see, the cyanotic heart diseases, 90% of them are dead by almost end of 1 to 2 years. And then you have the acyanotic heart diseases which linger on till around the third decade. And then from the third decade, there's a rapid fall in the survival curves. And then by much earlier, by around 60 to 70, almost all acyanotic heart diseases perish. So even though the survival curve, this is just survival curve, but it's important to realize that survival curve is not the most important thing in acyanotic heart diseases. Long before them, most of these patients would become inoperable. So it's very important that timing of surgery. Cyanotics, tend to get the notice and sympathy, and then they get treated much earlier. Acyanotics, we think they are sort of, okay, we can wait on them, and we end up in a trap, which I'll tell you later. So before I step onto the topic proper, one of the most important things is to realize that there is also a surgical group of patients in acyanotic heart diseases who have critical heart disease. That means if they come to your hospital with they come to you, you have to immediately treat them. That's coarctation with LV dysfunction. You cannot send them back and call them later. So if you have the other group in cyanotic heart diseases is obstructed TAPVC. These are the two diseases that remain absolute surgical emergencies. The other critical AS and critical PS, they are now mostly treated by balloon interventions or catheterization. So it's not truly a surgical subset. So there are several ways to classify acyanotic heart diseases. Now you can classify them based on where they're located, like atrial, ventricular, or a great arterial level, or you can classify them based on the size of their defect, a small, moderate, or large defect. But a practical way to understand the physiology of or the pathophysiology of acyanotic heart diseases is to classify them based on whether they're a dependent circulation or an obligatory shunt. So we'll just stick to left to right lesions. We'll forget the obstructive lesions for today for lack of time. So what do you mean by dependent shunts? Dependent shunts means that they are dependent on the resistance offered by the lung. So those shunts, the quantum of shunt that occurs in these lesions will be decided based on the resistance in the pulmonary vascular bed. That's called pulmonary vascular resistance, or PVR, which we'll be using it. The other group is obligatory shunt. Those shunts don't depend on what your PVR is. Irrespective of your pulmonary vascular resistance, they will shunt. Now, there are two major problems with these large shunts. The short-term problem is they go into cardiac failure. The long-term problem is that they develop pulmonary vascular disease or occlusive disease, pulmonary vascular occlusive disease, which is irreversible. And then the only option left is to do a lung transplant in these children. So let's take a typical VSD and let's analyze what really happens in a typical VSD. So most of the VSDs, when they're born, they're just absolutely normal at birth. They don't have any symptoms. And then what happens is in the first well baby examination, that's like around 6 weeks. So they start showing signs of tachypnea. They start showing signs of heart failure. And then they start faltering in growth. They start, developing respiratory infections. And by 3 to 4 months, they have their peak symptoms of cardiac failure. And then paradoxically, something happens. The body wants to protect the left ventricle. The body wants to improve the cardiac output. So what it does is it raises the pulmonary vascular resistance. I mean, it's a pathological response of the lung. But in effect, what happens is it starts reducing the shunt, and then the symptoms start improving. The babies start gaining weight, their tachypnea reduces, their tachycardia comes down, and you think actually the baby has settled and you can wait longer. But actually what is happening is the lungs are being destroyed at this point of time. So it's important to realize that after 6 months to 1 year, most babies with left to right shunts, even if they are improving clinically, are in fact getting worse. So why does this happen is if you look into the normal fall in the pulmonary vascular resistance in a newborn, most of them in utero have high pulmonary vascular resistance because the lungs are not aerated and you've got high resistance in them. Within the first 24 to 72 hours, almost 60 to 80% of the pulmonary vascular resistance comes down primarily because of expansion of the lung and vascular remodeling. And then for the next 6 weeks, there is a gradual fall in the pulmonary vascular resistance. And that's why the lowest pulmonary vascular resistance is usually between 6 to 8 weeks. And then what happens in cases of left-right shunts? What happens is after around 6 weeks, after around 3 months of remaining in low PVR situation, the pulmonary vascular resistance again starts to rise. More prominent in great arterial lesions, and then less in ASDs. So gradually the PVR starts to rise again. So you need to understand what is this pH. Several times you hear the patient has hyperkinetic pH, the patient has severe hyperkinetic pH, but patient is operable. So it doesn't mean that all pH are inoperable. So you need to differentiate between what's hyperkinetic pH and fixed pH. So there are 3 mechanisms by which you can produce pH. One is increased flow. If you have a tube of a fixed diameter, and if you try to push the tube can accommodate 5 liters flow, and if you try to push 10 liters, you're going to produce a high pressure proximally. So that's one mechanism. That's the mechanism called hyperkinetic pH. Then the next mechanism is, the tube has shrunk in size, and then you're trying to push this normal amount of blood flow. That also will produce pH. And the third form of pH is when there is something like mitral stenosis or chortriatriatum or a TAPVC, where there is an obstruction to the drainage. So these are the 3 fundamental mechanisms by which you can produce pH. So if you look at the way pH progresses in, I've removed the VSD because it takes months or years to develop. So if you take the PVR in VSD and PDA, you'll see that the first peak that occurs is the hyperkinetic pH that comes during the first few months and then it's gradually replaced by fixed pH later on in life. The fixed pH is primarily why it does occur is it's because the vascular remodeling of the pulmonary arteries in the lung. So they have an initial response when increased pulmonary blood flow occurs. The first response is it's for the muscles to hypertrophy, the muscular smooth muscle layer, that's the medial layer of arteries. They hypertrophy with lot of hyperplasia also. They undergo hyperplasia with lot of thickening. And then gradually what happens is the disease process shifts from the media to the intima. And then it produces intimal hyperplasia. And then towards the end, the intima itself gets destroyed. So those are the histologic changes that happen in the pulmonary arteries in PH. So the classification is something called Heath-Edwards classification. So it depends on how much of the intimal involvement is there and how much of the media involvement is there. And based on that, you know that somewhere between the more of intimal lesions occur, the more intimal lesions you have, the less chance of operability. So somewhere between the Heath grade 2 or 3, you become inoperable. Something beyond 3, you're almost inoperable. So, but we don't use this histopathology grading anymore, because there's a fundamental reason why we don't use histopathology grading, because all parts of it would have been very easy for us cardiac surgeons if we could decide, take a biopsy, put a small incision, take a biopsy of the lung, and then decide whether the patient is operable. The problem is that these vascular changes don't occur homogeneously in the lung field. Some parts may be more affected, some parts may not be affected. So you may not get the representative lesion. And some of these cases where you have high grade lesions, but some of them may put new units, functional units in the lung. And so they may actually, in spite of having a high grade, they may still remain operable. So we don't use biopsy anymore. So what do we use? So I always like to tell a story that happened during my MCH. I also worked in a very busy center. So at that time, exactly from where Dr. Amresh also did. So we used to have loads of preoperative patients coming to our OPD, and we did not have a way to really disperse them somewhere. So what do we initially do? We just take the echo form and write, kindly assess operability of this patient, and then send for cardiology. We just want to move them around, and then we don't have slots basically to operate. We were saturated. So we used to routinely send 5 to 10 patients to assess operability for patients. So suddenly one day one of the senior cardiologists came, and he put back the paper on me, and he said, see, this patient is operable clinically, radiologically, electrically, sonologically, and biochemically. Don't send this patient for echo anymore. So then I asked him, what's this clinically, radiologically? So he basically explained. So if you have clinical signs of failure, if a patient with a large VSD has clinical signs of failure, say for example, poor weight gain, fast breathing, tachypnea, tachycardia, and that means the patient is operable. That means the PVR is low. The pulmonary vascular resistance is low, so you can operate. And the next thing is, before you go on to the investigations per se, you should know how chambers dilate in each lesion. So if you take an ASD, so the ASD lesion is actually shunting from left atrium to right atrium. So in a case where there is a low resistance in the lung, you will see that all these chambers are dilated. You will have all the chambers dilating, and you will have pulmonary plethora in the lung. So you know exactly where, which are the chambers that dilate. So if you take a VSD, these are the chambers that will dilate. So it's from LV to RV. So all these chambers will dilate. So if it's from PDA, it will be from aorta to PA. And so you will see that an aorta, a dilated aorta, is almost indicative that there is a PDA also. So these are the ways you assess which are the chambers that have dilated. So if you look at it on an X-ray, to assess the operability, you know that anybody with, you look at, basically now these days you look at only practically two things. Do you look, is there cardiomegaly? If there's cardiomegaly and pulmonary plethora, that means this patient is almost always operable if he's got a left to right lesion. And this is a case of an Eisenmengerized patient. So you can see that the lung disease has progressed. So there is no vascularity in the peripheral 1/3 of the lung. So that's typical of Eisenmenger. The heart size has decreased and the PA size has dilated because of the pulmonary hypertension. So this is a typical picture of an Eisenmengerized lesion, and this is inoperable. So the other way is, the other additional thing you look at to assess operability is the ECG. So that's what electrically is. All newborns are born with right axis deviation. You should know that basic thing. So because if you accidentally see any child newborn with a left axis deviation, almost 80% of them will have a heart disease. So it's very important when you take an ECG, just to have a look at what is the axis. Is it right axis or is it left axis? So all children are born with right axis deviation. And then over time, over the first 2 months, the axis actually shifts and comes to the normal group. So in left to right lesions, what you will see is you'll start seeing this biventricular hypertrophy. You'll start seeing the left axis deviation going and right axis deviation going and beginning with the left axis also. This phenomenon is called the Kurzbachtal phenomenon, wherein you have large biphasic waves in mid-precordial leads. That's V2, V3, V4. You have these big biphasic waves. This is called, it's indicative of biventricular hypertrophy, and it's very pathognomonic of a large left-right lesion in as time goes, your left ventricular forces will reduce because your LV volume overload decreases, and then gradually what will happen is it will again become right axis deviation. So if you see right axis deviation in ECG in a large left to right shunt, you probably have already got an Eisenmengerized lesion. So then the next comes echo. So you look at echo, and on echo it's pretty much it's the mainstream of our, it's the Achilles heel of our evaluation. And if you have you look at basically the direction of the shunt, and then you look at the chamber sizes. Is the LA still dilated? Is the LV still dilated? Is there increased pulmonary blood flow in the pulmonary veins? Here it's not really possible to push everybody through a cath. So sometimes what we do is, where we have borderline operability blood flow, we just put them on a trial of oxygen, and then we see if there is increased flow happening. So that's one quick way to assess the operability. So the biochemically, the thing is, basically you look at the saturation. If the saturation is above 100%, you know that it's shunting left to right. If the saturation is below 100%, it's usually a right to left lesion. You know that deoxygenated blood is getting into the aorta. So, but it doesn't mean that all lesions with left to right lesions with desaturation are actually inoperable. There could be several reasons, like lung lesions or orthodeoxy or AV canal where there is streaming issues. So not all lesions with desaturation are actually inoperable. That's also one thing that's to be borne in mind. So one particular important thing about these left to right lesions is it's highly unpredictable who will get pulmonary vascular disease. In my own experience, I've seen 9-month-old children with irreversible PH. That means they will not they cannot undergo surgery. In just plain VSD, they have become inoperable. There are other cases where we have gone on for surgery in a 23-year-old with large VSD because it's still shunting floridly left to right. So it's highly unpredictable. So to truly, if you have a doubt how to make out is to do a cath. Cath is the ultimate gold standard to decide on operability. So one of the most important things that we do is we are able to do calculation of something called the pulmonary vascular resistance. So pulmonary vascular resistance will give you the direct vascular resistance. It's a big complex thing. So we just put them in Wood's unit. Paul Woods was actually born in India, by the way. So we assess the PVR. We try to get what is the resistance of it. And it's very important to know that one common mistake that is made, and I'm sure that if any of you are going back into pediatric practice, it's very important to realize that it may not be told by very clearly, that PVRI is fundamentally the unit that we use. That's what we use is we take the PVR and index it to the body surface area. That means you take the PVR and then divide it by the body surface area. But for a mathematical reason, in fact, several places where I personally visit and go, I've seen several people taking PVR and then dividing it by the body surface area. It's wrong. Always remember this, because I've had patients who were inoperable being treated as operable and then landing up in trouble. So it's a very important thing. It's actually PVR is not PVR divided by body surface area. Instead, it's PVR into body surface area, because actually it's because you're using for PVRI you're using cardiac index, so eventually it will go to the numerator. So you have to do PVR into BSA, not PVR divided by BSA. It's important to realize this mistake. In fact, there was a recent study and they looked and they found that 59% of published journals publish PVRI with the wrong formula. It was surprising actually. So based on PVR, we get this value called PVRI. And how do you decide on operability? So anybody who has less than 4 Woods unit is operable. Anybody with greater than 8 Woods unit, it is inoperable. You can do surgery on them, but then it's basically over now, because what was a disease of the heart has now become a disease of the lung. So what you do to the heart really doesn't matter, because you're not going to alter much on the lung. So always remember that. And then you can use another ratio called the PVR-SVR ratio to counter the errors that occur during a cath estimation. So using a value of less than 0.3, you may have signs of operability. These are just general broad guidelines, though you can adjust it into your own local practice. So it's always important to be aware of the fact that surgery delayed is surgery denied, just like justice delayed is justice denied. So if you wait, as time goes, patients will become inoperable. So they will live. In fact, many of them will be asymptomatic, but that doesn't mean you should keep them waiting, because the disease is progressing. It's just like HIV. The moment you are infected, if you don't treat, you will get AIDS faster. So the disease process is happening underground. There's nothing that stops. One of the saddest things is all that we said was for the large lesions. Now there's something sad that happens to these moderate lesions and small lesions. Now these unfortunately are told by our own people, I mean doctors in our own field, that, oh, this is a very small lesion, nothing will happen, you can go home, it will close. No heart lesion is benign till you have made sure by objective mechanisms, either an echo or a cath, that something has closed and has disappeared. No assumption. Assumption is a big problem in cardiac surgery or cardiology as a whole, because no lesion will close without you confirming it is closed. So many parents will actually go home and say, in fact, I just wanted to show you this echo. This echo is a 12-year-old child who was diagnosed, just an award now, is 12-year-old child diagnosed at 6 months of age having a small VSD. Somebody told her, don't worry, nothing will happen, it will close by itself. 12 years later, the patient comes back with severe AR. So small lesions also create problems. Several of these small lesions also, this was something that could have been just closed as a small hole, now has come back with a hole and one of the valves leaking now. This could have been prevented if the VSD was closed. So it has come back with such a much worse lesion. So it's very important that patients are kept on follow-up. We are able to repair, but definitely it's not adequate. In some time in the future, again, the patient will undergo a valve leak. So luckily for us, unlike many other countries in the world, we have a guideline on exactly on when each patient should be treated. This is a very good. If you scan the QR code, you'll get the PDF directly on your mobile. It's wonderful to have this thing, and it's a great step forward that we have taken to create this guideline for all these patients. So it gives the exact timing of surgery for each lesion. So my take-home message is, in acyanotic heart diseases, pulmonary vascular disease is the villain, and it's very unpredictable. You might have seen some child who did not develop pulmonary vascular disease till 10 years. There will be another kid who will develop it at 1 year. And acyanotic lesions, most of them are curable as long as you treat them in a timely manner. So the key thing is don't delay. One of the biggest problems that I faced when I was in Chitra is we used to have 4,000, 5,000 patients in the waiting list. And we could not practically refer these children to anywhere because being in a public sector hospital, we couldn't do that. But I just keep saying, I used to keep this motto, don't delay, just relay. You pass on the baton to someone else who can do it, get them done, because we cannot lose children which are imminently curable because of unwanted delays. And no acyanotic lesion is actually benign. Almost always follow them up till they are cured. Thank you.
Any questions?